Please, I would like to announce the next speaker, our good friend from Norway, Professor Unnsgard, please.
I want to thank my good friend Alexander Potapov for the invitation to this meeting at Burdenko. I have met both Professor Konovalov and Professor Potapov at different events around the world, and I must say that they are both extraordinary persons, friendly in spite of their high position in neurosurgery. It is an honor to have the opportunity to present our experience with 3D ultrasound technology here at the Conference on Neurotrauma and Neuro-Oncology. I come from Norway and from the city of Trondheim, not Oslo as written in the program. Trondheim is the technological capital of Norway. My hospital is St. Olav University Hospital, and my university is Norwegian University of Science and Technology, NTNU. The medical faculty of NTNU is integrated into St. Olav University Hospital. I'm also proud to say that two neuroscientists from my faculty, May-Britt and Edvard Moser, received the Nobel Prize in Medicine 2 days ago in Stockholm. When we built the new Neuro Center at St. Olav University Hospital in Trondheim in 2005, we decided to use 3D ultrasound instead of MR for intraoperative imaging. One reason for our decision was positive experience with 3D ultrasound for many years. Another reason was that 3D ultrasound is an inexpensive and flexible solution. We use intraoperative 3D ultrasound for a wide range of applications. Since one of the themes of the conference is oncology, I'm going to speak only about the use in glioma surgery. We use it in every glioma operation. And the equipment we use is Sono1. The Sono1 Invite integrates both conventional navigation based on pre-op MR or CT and intraoperative imaging based on 3D ultrasound. There are several probes available to the Sono1 equipment, both linear array probes and phased array probes. The last 5 years, we have mainly used the linear array probes, which give excellent demarcation of the tumor borders. Here in the middle column, you see both the coronal and sagittal view of a low-grade glioma before start of the resection. And to the right is after having resected 1/3 about of the tumor. It's very well demarcated, just like an MR. It's also easy to see when all tumor tissue is removed. Here everything is removed. The way we acquire 3D volumes is by tilting or translating a proper probe over the area of interest. About 200 images are acquired and converted into a 3D volume with precise positioning. This 3D volume can be navigated in either with a pointer or a surgical instrument with a position frame attached. In conventional neuronavigation, there are different sources for inaccuracy: registration inaccuracy, technical inaccuracy, and brain shift. The registration inaccuracy can be between 5 and 10 millimeters. The brain shift can cause an inaccuracy of several centimeters. With 3D ultrasound, this is different. There is no registration inaccuracy because 3D ultrasound images are acquired and displayed in the same reference system. And there is very little brain shift inaccuracy, because due to the simplicity of making new images, the navigational map can be updated several times during an operation. We typically make 5 to 6 new images during the operation, so the inaccuracy due to brain shift is very low. To increase the precision of resection, I resect with navigated CUSA. And how can 3D volumes be displayed in the best way? Most surgeons are used to actual coronal and sagittal planes. Any plane defined by a pointer or a navigated CUSA is, in my opinion, easier to use during the operation. And a plane perpendicular to this plane can be added, making it a dual anyplane. So to the resection of high-grade gliomas. Even though we often use 3D MR for planning and background for superimposing the 3D ultrasound volume, we can also use 3D ultrasound alone, as in this glioblastoma case. We drape ultrasound probes. In this case, we use 2 probes. We are testing out different probes. And then trackable CUSA, freehand 3D ultrasound. And you see here the image on the monitor. And you also see the angiography. And here is the 3D volume, and you can navigate in this ultrasound-based volume. Calibrate the CUSA, and then resection with CUSA. And when you move the CUSA, you also see the image is moving all the time. And then you carry on. Here is only part of the tumor removed. And then you go on with more resection, and at the end, more and more of tumor is removed. And here is the different stadium of this glioblastoma operation: before, in the middle, and at the end, where everything is removed. And post-op MR 1 day after the operation shows gross total resection. And notice also the normal, the cavity is less than half of the tumor volume because of the shift. No neurological deficit after the operation. Some years ago, we published material of high-grade tumors operated from 2007 to 2009 by 9 different surgeons, both seniors and residents, some of them with very little experience with ultrasound. And good image quality was obtained in 83%. In a subgroup of patients with the same inclusion criteria as in the German 5-ALA study, the gross total resection was 63%, the same as for the 5-ALA study. 3D ultrasound is even better for resection of low-grade than for high-grade gliomas, because in low-grade there is no disturbing edema. These low grades in insula and in the frontoparietal region is very well demarcated from the normal brain. But in some low-grade glioma cases, the demarcation of the tumor border is diffuse on the 3D ultrasound images. And I never dare to remove tumor tissue that is hard to see in the 3D ultrasound, because I have a few cases where stimulation have indicated functioning brain tissue in these locations. So I would, of course, remove this one, but this part, which is also shown as tumor in the flare, I would not dare to remove, because here I think it's a lot more normal cells than in the rest of the tumor. A rule that is dependent on optimal image quality. A phased array probe is not good enough to demarcate a low-grade glioma, as you see in the middle column of this case. With linear array probe, as shown to the right, it is possible to see the different cell densities and hotspots, probably representing hotspots. The workflow of low-grade glioma operation, in insula operation, the first part of the operation is just like any with registration and planning, like using a conventional navigation system. And then some extra, you have to drape the probe. That is the only extra thing you have to do, actually. And then ultrasound acquisition from dura. And you see, look at this and look at the quality and see that the quality is good enough, and then do the first ultrasound acquirement, and then do the navigation, and you see that this tumor is shown very well. And also you have the insula arteries here as well with the power Doppler angiography. And the microscope, the navigated biopsy, and then planning of access. And I use transcortical access in all these cases. And then resection with navigated CUSA. And as you see, when you start to do the operation, the image is changing all the time to have the tip of the CUSA in the image. And then a new 3D volume. And then some of the tumor has been removed, but not all. And then we go on, more and more of the tumor is removed. And at the end, everything is removed, and the insula vessel is hanging freely in the cavity. And the patient was very well the same afternoon. MR 1 day after the operation showed gross total resection of this low-grade astrocytoma on the dominant side. There was only some air and bloody water in the cavity. No neurological deficit. During resection, it's easy to see even small residual tumor, as you can see here at the yellow arrow in the middle of the monitor. In the last image of the monitor, you see that the residual tumor is removed and the cavity is larger. And below the bottom of this cavity at the green arrow, there is an artifact signal that I will come back to later. This is a movie from a live operation in one of our international training courses showing what is displayed on the screen in the auditorium. This is a frontoparietal tumor, acquisition of image from the dura. See the tumor well. And then you take a biopsy, you set the target for the biopsy, and here's the target. And then you go down with the biopsy forceps to hit this target, take a biopsy, and here you also see the brain shift. It's considerable brain shift. This is the surface of the brain actually during the operation. And then operate with navigated CUSA. This is after some operation where some of the tumor is removed, but still a lot of tumor left. And we go on, and at the end, we do a resection control, and here everything is removed actually, as we can see by the ultrasound image is. And that post-op MR 1 day after the operation shows gross total resection This young lady had a small paresis in right hand, probably due to a small infarction in the presental gyrus. But the movements of the right hand were normalized in a few days. I always operate with navigated CUSA, and this is especially helpful in cases with deep-seated tumors, where you have to go through a lot of normal tissue to reach the tumor. There are two cases these are two cases that were operated on the same week about a year ago. They had both tumors in the amygdala region, right and left. And we operate these lesions through a small temporal craniotomy. And positioning and planning, try to go through the inferior temporal gyrus. And here you see the tumor is coming. You do the acquisition. And here is the 3D image of the tumor, and it's shown very well. And then we take a biopsy first, set the target, go down with the biopsy forceps. Here we hit with a biopsy forceps. Then we go on with the navigated CUSA and do the resection. And you see here is the tip of the CUSA, go along the border of the tumor here. And after some resection, there is still some tumor tissue left, as you can see here. And we have to go on with more resection with navigated CUSA. And here is from the operation, movement of the CUSA in this part of the tumor. At the end, we also do some stimulation, and it was only 4 millimeters from the pyramidal tract here. Resection control showing that there is this looks okay. And this is the other case before resection. During the resection, still some tumor tissue left, and at the end, everything was removed. Here is an artifact, probably a clot. And the radiology department reported gross total resection in both cases. No permanent neurological deficit was registered, except for a hardly noticeable semantic paraphasia for patient B. In eloquent areas, we always use functional MR integrated into the 3D MR volumes for planning. During the resection, we have to rely on the 3D ultrasound. 3D MR cannot be trusted because of registration inaccuracy and brain shift. But it's still useful to know about where the eloquent structures are located. We also use stimulation to identify cortical and subcortical eloquent structures. Some years ago, we reviewed our results of operating gliomas in eloquent areas using preoperative fMRI and tractography imported into the SONO-1 system and combined with intraoperative 3D ultrasound. We obtained gross total resection in 42% of all the tumors, and only 3% suffered neurological worsening due to surgical manipulation. We have some strong evidence for the clinical effectiveness of our way of handling low-grade glioma patients. Together with another university hospital in Norway, a thorough survey was done of patients treated for glioma grade 2 since 1998 at our hospital, and the other hospital named A here. Pathologists from both hospitals verified the diagnosis at the other hospital. At our hospital, B, we have had an aggressive strategy with 3D ultrasound-guided resection in 82% of cases. The other hospitals have had a more traditional strategy with initial biopsy, regular MR controls, and later resection when growth of the tumor was observed. There was no significant difference in none of 26 other baseline parameters that could possibly influence the results. And because of the socialized medicine in Norway, all the patients belonging in a region are referred to their own university hospital, making it kind of a geographical randomization of treatment. The study was published in JAMA last year, and this is a figure from JAMA showing an impressive survival benefit for the patients treated at our hospital, mainly with the 3D ultrasound-guided resection. It's also important to notice that the survival benefit is increasing with time. The median survival is probably more than doubled in the patients operated at our hospital. Another very important result was that there were no significant difference in complications between the patients treated at hospital A and B. So radical resection with Sono-1 is very safe and done properly. The previous figure was based on the whole material, also including patients that were not treated according to strategy. But when looking at survival of patients treated according to the preferred strategy, the difference was even larger. 5-year survival for the low-grade gliomas resected with navigated 3D ultrasound guidance is 81%. And none of the patients in this series were operated with wake surgery. And updated median survival of patients treated with 3D ultrasound seemed to be more than 15 years. A quality of life assessment was done retrospectively on the surviving patients. A radical resection by 3D ultrasound did not affect the quality of life. So, in conclusion, 3D ultrasound is a useful tool for resection of all kinds of gliomas. 3D ultrasound and navigated CUSA is especially helpful when we operate through a small opening in the normal tissue and when the tumor tissue is very similar to normal tissue, so it's difficult to differentiate in the microscope. For low-grade glioma, early and radical resection guided by 3D ultrasound will at least double the median survival compared to a wait-and-see strategy. And most important, this operation is a very safe procedure without any negative influence on neurological deficit and the quality of life. At the end, I will tell you about the project that we are doing right now. A challenge in ultrasound-guided operations is the ultrasound image artifacts that sometimes may be seen towards the end of an operation. I think these artifacts are one of the main reasons why many surgeons are reluctant to use 3D ultrasound for intraoperative imaging. Here you see what can happen towards the end of an operation. As more and more of a large tumor is removed, you see some artifact signal below the tumor. And here it's impossible to see the border because all of it looks like tumor. And the cause of these ultrasound artifacts seen towards the end of resection is different attenuation of sound waves in the brain tissue and in the saline that is used to fill the operation cavity. These images from different stadium of a low-grade glioma operation I have already shown. The green arrow below the bottom of the cavity points to an enhancement artifact, signal that occurs because the sound signal has gone through this large cavity. And it might look like a residual tumor, and you can avoid this pitfall by comparing to earlier stages of the operation where it's no signal below here. And in addition to comparing with early 3D ultrasound values, there are several other ways to cope with these enhancement artifacts. One way is to use a phased array probe at an angle to the operation cavity In that way, the traveling distance for the sound waves through saline is reduced. The same effect is obtained by using a small probe into the cavity, as you see in the last column here. The middle column shows the 3D ultrasound image acquired with a linear probe through this large cystic tumor, and a lot of artifacts here makes it impossible to really see the tumor border. To the right, we have smaller probes into the small probe into the cavity. You get closer to the wall here, and a shorter distance to travel through water, and you really see the border of the tumor, as you can see here at the yellow arrow. But it's a bit cumbersome to use a small probe in the cavity. A more elegant way of reducing these artifacts is to fill the operation cavity with a fluid with the same damping effect on sound waves as the brain. And we have developed such a brain-mimicking fluid here named acoustic fluid. We have tested the safety of this acoustic fluid in 2 series of animal experiments, and there was no reaction in the brain whatsoever, not even after injection in the brain. And less than a year ago, we started the clinical phase 1 technical and safety study, and so far we have included 10 patients, mostly large tumors that we know will give artifacts towards the end of the operation. Here is an example with saline in the operation cavity. It's impossible to see any details here below the cavity. And when the cavity is filled with acoustic fluid, this tumor becomes evident here at the yellow arrow. So it functions as expected. But of course, we need some more patients to draw a conclusion. The preliminary conclusion is that the acoustic fluid seemed to be well tolerated by the patients. No specific adverse events has been observed. It's easy to work with the fluid. It's white, so it's easy to see when everything is removed, and it seemed to work as expected. These are some of my co-workers at the Center of Competence for 3D Ultrasound in Neurosurgery in Trondheim. Thank you.
Thank you very much, Professor Unnsgard. Thank you. Let me give you the diploma, because you are invited speaker of the Burdenko Neurosurgery Institute. Thank you.